My name is Lee Tjoa. I am the Senior Global Medical Affairs Lead for the autoantibody and maternal-fetal immunology programs at J&J. So I sit within the Global Medical Affairs Division in the immunology therapeutic area. So we support a lot of work around scientific engagement. So this would be data dissemination, data communication, working with thought leaders on different types of educational and data generation activities. So we do a lot of work for the maternal fetal programs in terms of supporting the trials that are ongoing, as well as understanding the landscape of the indications that we are currently pursuing clinical trials in. And what I mean with landscape is the medical landscape. So, what are the patient journeys? What do patients go through in terms of seeking care, the diagnostic, as well as the treatment challenges that they face, and of course, clinical outcomes. So, what happens after a pregnancy that has been affected by HDFN and FNAIT? What happens to the babies? What happens to the women themselves? The choices that they may be facing. So HDFN, or hemolytic disease of the fetus and newborn, is a rare alloimmune condition of pregnancy that may also have some very traumatic and life-threatening outcomes. So it is caused by a mismatch between antigens on red blood cells. So these are proteins on red blood cells. And if there is a mismatch between the antigens on the red blood cells of the mother and of the fetus, then the maternal immune system will kick in and may start to produce alloantibodies. These maternal alloantibodies can cross the placenta and cause destruction of the fetal red blood cells. So the maternal alloantibodies basically recognize the fetal red blood cells as being foreign. And when they cross the placenta, they would attack these fetal red blood cells. So this can lead to fetal anemia. If fetal anemia is not diagnosed in a timely manner, or if it is not treated, then more severe outcomes can occur. And these more severe outcomes include fetal hydrops, potentially leading to cardiac failure and fetal demise. And then after delivery, the anemia can persist in the newborn, and this can lead to some severe outcomes, including hyperbilirubinemia. And when it's very severe, then babies may need to undergo an exchange transfusion. But many babies who are born with HDFN do wind up in the NICU for a certain amount of time, where they will receive other medical interventions, including intensive phototherapy, as well as simple transfusions. We actually did a study. So my colleagues in the epidemiology division looked at what are some of the outcomes associated with IUTs. So to start off with, though, I just want to make sure that it's understood that IUTs, these are intrauterine transfusions. These are invasive procedures that are performed in order to try and correct fetal anemia. So, adult blood is transfused to try and treat the anemia in the fetus during pregnancy. So, as you can imagine, these are highly complex procedures. And there does appear to be an association with a higher rate of preterm birth, as well as an increase in the need for a cesarean section. What we found in this study is that 13% of pregnancies that were treated with an IUT did require a delivery by C-section within 24 hours of the IUT being performed. So this is indicative of, some of the downstream effects of having an intrauterine transfusion. There was a study that was performed again by another group of colleagues at Johnson & Johnson. So this particular study looked at healthcare resource utilization associated with HDFN in Sweden. So they looked specifically at outcomes associated with having had an IUT during pregnancy, or if an infant was born with HDFN and required a transfusion after delivery. What was found in this particular study is that healthcare resource costs associated with HDFN were higher than what you would see, let's say, in a non-HDFN affected population. So this includes things like NICU admissions, the need for transfusions, and other direct medical costs. What was surprising in this particular study was that the cost of medical care for those infants that did not require an intrauterine transfusion, but did require a postnatal transfusion, was much higher than those infants that did receive intrauterine transfusions during pregnancy. So, what is the possible cause of this higher rate of medical cost is not clear yet. And so more research will be needed to understand what the implications are of the medical interventions that they receive and how this affects medical costs. But overall, the cost of having an infant or a pregnancy affected by HDFN is higher than that of non-HDFN affected pregnancies. And this actually persists beyond the first year of life. So this higher need for medical care and therefore increased medical costs persists beyond the first year of life for infants affected by HDFN. The data that we presented at ISUOG a few weeks ago really highlights the lived realities and the lived experiences of pregnancies that were affected by HDFN and FNAIT. So we explored the treatment patterns and outcomes associated with IUTs. We also looked at what are some of the clinical outcomes associated with HDFN, but we also looked at what were the patient perspectives on having had pregnancies affected by these two rare diseases. And what we found is that patients highlight how much self-advocacy and self-education they require to be able to navigate these complex pregnancies, and also the need for emotional support as they make decisions regarding treatments, as they make decisions regarding care for their babies, and also after delivery, understanding what the implications are for them moving forward in their family planning choices. So what I would say is that the data that we have presented and the work that we are doing or continue to do reinforce the need to move forward with innovations for HDFN and FNAIT. And we believe that there is a possibility to transform the way that these pregnancies are currently managed. So one of the things that I did want to mention was around FNAIT, which is the other rare alloimmune condition of pregnancy that we presented data on. So FNAIT stands for fetal and neonatal alloimmune thrombocytopenia. It is similar to HDFN in that it is also caused by maternal alloantibodies. In this case, however, the maternal alloantibodies attack fetal platelets and cause low platelets in the baby. What we have learned is that the diagnostic journey for determining FNAIT in a baby is very complex. And patients have highlighted how confusing that diagnostic journey is and how that impacts them as well, causing a lot of fear and confusion. And not knowing what the implications could be for them and for their families moving forward. So similar to HDFN, there is a great unmet need for a better understanding of FNAIT, how you can diagnose FNAIT, how you can treat pregnancies at risk for FNAIT, and how this information is also relayed to patients, because they do want to know more. They want to learn more about these diseases. At J&J, we are committed to continuing the work that we're doing in these alloantibody-driven diseases.